This lecture will go over hyperaldosteronism. Hyperaldosteronism is an increased secretion of aldosterone with mineralocorticoid excess. Primary hyperaldosteronism diagnosed in adults results from excessive secretion of aldosterone from one or both adrenal glands, usually caused by an adrenal adenoma. In secondary hyperaldosteronism, excessive secretion of aldosterone is caused by the high levels of angiotensin II that are stimulated by high plasma renin levels. Some causes include kidney hypoxia, diabetic nephropathy, and excessive use of some diuretics. Increased aldosterone levels causes disturbances of fluid and electrolyte balance, which then trigger the kidney tubules to retain sodium and excrete potassium and hydrogen ions. Hypernatremia, hypokalemia, and metabolic alkalosis result. Sodium retention increases blood volume, which raises blood pressure, increasing the risk for strokes, heart attack, and kidney damage. Hypokalemia and elevated blood pressure are the most common problems that patients with hyperaldosteronism develop. He or she may have a headache, fatigue, muscle weakness, dehydration, and loss of stamina. Polydipsia and polyuria occur less frequently. Paresthesias may occur if potassium depletion is severe. Hyperaldosteronism is diagnosed on the basis of laboratory studies and imaging with CT or MRI. Serum potassium levels are decreased and sodium levels are elevated. Plasma renin levels are low and aldosterone levels are high. Hydrogen ion loss leads to metabolic alkalemia. Urine has a low specific gravity and high aldosterone levels. Surgery is a common treatment for hyperaldosteronism. One or both adrenal glands may be removed. The patient's potassium level must be corrected before surgery. Drugs to increase potassium level include spironolactone, a potassium-sparing diuretic, and aldosterone antagonists. Potassium supplements may be prescribed to increase potassium levels before surgery. The patient may also benefit from a low-sodium diet before surgery. The patient who has undergone a unilateral adrenalectomy may need a temporary glucocorticoid replacement. Replacement is lifelong if both adrenal glands are removed. Glucocorticoids are given before surgery to prevent adrenal crisis. The patient receiving long-term replacement therapy should wear a medical alert bracelet. When surgery cannot be performed, spironolactone therapies continue to control hypokalemia and hypertension. Because spironolactone is a potassium-sparing diuretic, hyperkalemia can occur in patients who have impaired kidney function or excessive potassium intake. Advise the patient to avoid potassium supplements and foods rich in potassium when taking spironolactone. Hyponatremia can occur with spironolactone therapy, and the patient may need increased dietary sodium. Instruct patients to report symptoms of hyponatremia such as mouth dryness, thirst, lethargy, or drowsiness. Teach them to report any additional side effects of spironolactone therapy, including gynecomastia, diarrhea, drowsiness, headache, rash, urticaria, confusion, erectile dysfunction, hirsutism, and amenorrhea. Additional drug therapy to control hypertension is often needed.